Hi, everyone. Welcome to our Research Week webinar. I'm Robert Wilson, Manager of Quality of Care NL. Before we get started, I just have a few housekeeping notes. The chat box and Q&A feature are both open, so please feel free to use them. You can turn on your subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And finally, the session is being recorded and will be hosted to Quality of Care NL's YouTube channel. I'd like to start with an acknowledgement that the lands on which Memorial University campuses are situated are in the traditional territories of diverse Indigenous groups, and we acknowledge with respect the diverse histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We invite everyone to offer land or territorial acknowledgements in the chat and take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. This week is World Antimicrobial Resistance Awareness Week, a global initiative to help educate the public on the dangers of antimicrobial resistance and what that means for future use of life-saving drugs like antibiotics. Today, we are joined by Dr. Peter Daley, infectious disease physician and co-chair of the Provincial Antimicrobial Stewardship Committee. We'll also hear from one of my colleagues, Michael Barrett, a research assistant with Quality of Care NL. So if you have any questions throughout the presentation, please feel free to type them in the chat or Q&A box, and hopefully we'll have time to cover them all at the end. So let's get started with our presentation. So Michael, if you can advance to the first slide there. Just to give you a bit of context of who we are, Quality of Care is an applied health and social systems research and evaluation program aimed at improving social and health outcomes in Newfoundland and Labrador. We're a collaborative effort between the leading healthcare entities in the province, and our goal is to improve the quality of care by facilitating change to ensure the right treatment or service gets to the right patient or person at the right time. We also have a partnership with Choosing Wisely Canada, which is the national voice for reducing unnecessary tests and treatments, or otherwise called low-value care. We lead the learning health system of NL Support, one of 11 support units across Canada under the strategy for patient-oriented research. So just advance the slide there, Michael. So after the recommendations that came from the Health Accord, we expanded the concept of a learning health to the social system because there was such a focus on the social determinants of health. So Quality of Care NL operates on the principles of that learning health and social system, one that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, resulting in better care and health for all. Next slide, Michael. So this is just to kind of give you an idea of the framework of a learning health and social system. I'm not going to get into too much detail, but there's three major components. On the very bottom, you have your pillars through social, scientific, technology, policy, legal, and ethical. And in the middle is learning health and social system processes, and otherwise called learning cycles. And at the very top is the learning health and social system outcomes that consist of health equity, the pursuit of better health, workplace well-being, improved outcomes, and value. And this is otherwise known as the quintuple aim. So just continue on, Michael. So I just kind of want to dive into the very center of that framework, which is the learning cycles. At the very center of this, you'll see a problem of interest. And for this example right now, we're talking about the overuse of antibiotics and antimicrobial resistance. And with that, we want to involve a learning community. And the learning community involves all stakeholders, which is the patients, public, frontline workers, policymakers, researchers. And so there's three huge components or major components to the learning cycle, which is the data, which we collect the information, and then we take that information, the data, and transfer it into knowledge, otherwise known as knowledge translation. And then from knowledge translation, we try to put that into practice so the system gets better. And the cycle continuously goes round and round, trying to continuously improve itself. Next slide, Michael. So I'm going to pass it over to Dr. Peter Daley to kind of dive into antimicrobial resistance and the overuse of antibiotics.
Thanks, Robert, and good morning. Thanks for joining us on World Antimicrobial Awareness Week. This is the week of the year that we focus on the problem that we are running out of antibiotics in this world. And this is a dangerous problem because what's happening is antibiotics are being overused, and bacteria that live on us and in us, called the flora of our bodies, are becoming progressively more drug resistant. And that means when we do get sick with bacterial infections, often the antibiotics that we would normally use don't anymore work. So this is an important ecological concern, and we're focusing today on this particular quality problem in the context of all the other quality improvement and learning health system initiatives. Next slide. So now we have increasingly good data showing the impact of antimicrobial awareness antimicrobial resistance globally. And we know that nearly 5 million human deaths have been associated with bacterial antimicrobial resistance, mostly focused on low and middle income countries. And we know at the same time that we're losing the effectiveness of these drugs, that the pharma companies are not producing new drugs at the rate that they used to be. And that is because these drugs are simply not profitable for pharma. So we're seeing a increasing failure of antibiotics with a decreasing production of new antibiotics. And this is the exact ecological crisis that we're facing. We know this is a big problem. It's not only what antibiotics are used in humans, but antibiotics used in animals, antibiotics used in the environment, and antibiotics used around the world. This is a global ecological crisis. Next slide. And so we started to measure the impact of this, and that we could be looking at a very expensive problem over time, that the AMR problem will reduce global annual GDP by 3.8% by the year 2050 if things continue to go in the wrong direction, and that we know that we can't only work within humans, but it's got to be in the context of prevention of infection and vaccination and hygiene and hand washing and all the other healthy initiatives that we use to protect us and prevent these types of infections. Next slide. So here's a case from the hospital that may illustrate what we're talking about. And some of you may understand how we take care of patients in hospital. This is a 78-year-old lady. She lives in a nursing home, and she gets antibiotics on a recurrent basis for urinary tract infection. And we see this commonly in the long-term care facilities. Patients get antibiotics after antibiotics. Some of those treatments may be necessary, but many of those treatments are unnecessary. So when we talk about unnecessary treatments, we say, why are we wasting time giving a drug that doesn't help the patient? But more importantly, is that harmful ecologically? Is it leading to selection towards antimicrobial resistance? And what happened to this lady? She became feverish, and she was transferred from the long-term care facility into the hospital facility. And she was given an antibiotic that we would commonly use, that we would expect should work. We call that empiric therapy, and it's our best guess until we have culture data to inform us on the correct antibiotics. So we gave her a drug, ceftriaxone. That's a third-generation cephalosporin. Generally works well for serious urinary tract infections. But the patient did poorly, and so she deteriorated, and then actually required life support system with blood pressure support to keep her alive. In other words, the antibiotic was failing. Over the next 3 days, she finally got the blood culture and susceptibility result reported, and it turns out that she had an infection caused by a germ called E. coli, which was extremely drug resistant. This particular bug had an enzyme called an extended spectrum beta-lactamase. And we quickly changed antibiotic therapy, but for this lady, it was too late, and she died of infection. Now, had she received the correct antibiotic on admission, she might have survived. That is to say, antimicrobial resistance led to inadvertent, incorrect antibiotic treatment, and she had a poor outcome in this case. So this is an example of exactly what we're facing, and we deal with this every day in the hospital with our infectious disease consult service. Next slide. So then we say, if this problem is an ecological problem, it's a global problem, what can we do? Well, we certainly need to use antimicrobials in the hospital for patients with life-threatening bacterial infections. That is saving lives. The question is, why are we giving antimicrobials to people with mild infections in the clinic? In other words, if I have a cough and a sniffle, it's probably caused by a virus. There would be no reason to take an antimicrobial, that's an antibiotic or antibacterial drug, such as amoxicillin or trimethoprim sulfa or doxycycline. And the answer is that's inappropriate, harmful therapy, but unfortunately, it happens all the time. So you may ask yourself, how many times have you taken an oral antibiotic for a mild, self-limiting, viral upper respiratory tract infection? And we're going to talk about each of these syndromes: sinusitis, pharyngitis, acute bronchitis. This is inappropriate and harmful therapy. So what do we need to do? We need to make the public aware, and that's the purpose of this presentation, that it may be unnecessary to take an antibiotic and furthermore may be harmful to this ecological problem. We need to reverse the trend of increasing antimicrobial resistance by reducing antimicrobial usage. And we're talking to patients and we're talking to doctors, and we're trying to make a change in the pattern of antimicrobial use in this province. And that requires changing some old ways of thinking. And you may have heard this from your grandmother. You need an antibiotic if you get a cold and a sniffle. And furthermore, I have some stored up in the medicine cabinet in the bathroom. This is also inappropriate use and should not be given for these types of syndromes. Next slide. Michael, do you want to get into this, or shall I talk about this?
You can go ahead and I'll introduce the next slide, Peter. Thank you.
Good. So let's look at trends in antimicrobial usage. And unfortunately, we have to admit that the eastern part of Canada uses antibiotics more than central and western Canada does. And we don't have any good reason for this, because there's no difference between us as Eastern Canadian, Atlantic Canadians, and the Central and Western. It's not that we need these drugs. It's rather that we're using them unnecessarily. And the estimate is between 30 and 50% of outpatient antimicrobial usage should never have been taken. That is unnecessary and harmful. Now, the good piece of the news is that we're seeing reduction over time. In fact, during COVID-19, we saw significant reduction. So we're happy to say that this kind of antibiotic addiction that we have in this part of Canada seems to be improving. So we're very happy with that trend. Next slide.
So I'm just going to kind of talk about the approach by quality of care and choosing wisely NL. This has been our longest kind of standing evaluation project since we first started the program. And so the goal was to reduce the overuse of antibiotics in Newfoundland and Labrador. So we had a multifaceted approach. One was to actually educate the public and patients on the appropriate use of antibiotics and when antibiotics were needed. The second approach was to provide medical education to healthcare providers on the appropriate use and their actual prescribing behaviors. And then, of course, we were going to measure and evaluate the progress of these interventions over time to see whether any of these interventions had any sort of effect reducing the overuse of antibiotics. So next slide, Michael. So just to kind of give you a snapshot of some of the things that we've done to kind of get public and patient engagement, we've provided viral prescription pads to healthcare providers that they could give their patients if they were asking for an antibiotic. We pushed out posters that healthcare providers could put in their clinics on the appropriate use of antibiotics, along with one-pagers that healthcare providers could provide to their patients. And this was kind of targeted towards mostly the vulnerable and high users of antibiotics, which included children and the older population within Newfoundland and Labrador. And we also provided and created some YouTube videos that showcased the dangers of overuse of antibiotics and when antibiotics were needed. Next slide, Michael. So, since the inauguration of the pharmacy network, which provides data of all prescriptions within the community in long-term care, we've had a rich database and rich source of information of the prescriptions that are occurring within Newfoundland and Labrador. And one of the methods that we've used for medical education was audit and feedback or peer comparison. So with partnerships with the Newfoundland and Labrador Medical Association and the College of Registered Nurses, we were able to provide all providers or primary care providers in Newfoundland and Labrador their actual prescribing habits. This was all done in a blinded way, so no one knew how much each actual healthcare provider was prescribing. But the way we provided this information was with basically the overall data across the province. And then they could actually dive deep into their actual personal report, which gave information on what kind of antibiotics they were prescribing. And then that compared it to their actual peers across the province. So if you move on to the next slide there, Michael. So this just kind of gives you an example of the information that they would get. You can see that on this graph, it's ranked by actual family physicians and the volume of prescriptions they got in 2 time periods, before COVID and during COVID. So when a family physician or nurse practitioner would click on their actual report, they would actually see a dot that showcased where they lied within the graph. And this compared them to their peers across the province. Next slide, Michael. So I'm going to pass it over to Michael now, who is our lead analyst with antibiotic prescribing Newfoundland and Labrador, just to kind of dive into the newest information that we've obtained.
Thank you, Robert and Peter, for talking about the issues that we're facing and also what we're trying to do. So keeping that in mind, you've heard that the problem that we face in our province is that unfortunately, we have the highest usage of antibiotics in the country, especially in the Atlantic provinces. And we've also seen the greatest decrease since after COVID, so the Atlantic province have been credited with that. What we're looking at here is we're trying to understand where we're actually going, especially at a local level. So using the data that we have, we can look at something called the antibiotic prescription rate. So this is simply just the number of prescriptions per 1,000 population. And then we've got it shown over the same 5-year period as previous reports, but just in terms of Newfoundland. So you can see that while there was a decrease since COVID, the numbers have started to go up, not by much, but certainly by a little bit. So just looking at the number of prescriptions monthly will give us an idea of seasonal trends. So as you can see, around August, which is coincidentally when the government lifted the mask mandate and permitted more indoor gatherings, the number of prescriptions for antibiotics definitely saw a spike after that period. So there could be a number of reasons for this, but it came at an interesting time, especially when seasonal trends for flus also tend to go up. All right, sorry, I'm just gonna go back. So what this slide is supposed to show, I'm sorry, I don't know why the title is not there, is called the WHO Aware proportion of prescriptions. So the WHO, or World Health Organization, has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So what AWARE means is Access, Watch, and Reserve. It's actually an acronym, which stands for a system that was developed by the WHO, grouping antibiotics according to their spectrum activity and also the risk of developing antimicrobial resistance. The access group, which is this green part of the chart here, is narrow spectrum antibiotics with low resistance potential. The yellow group is the watch group, which is broader spectrum with higher resistance potential. And finally, that little tiny blue is the reserve group, antibiotics that should be considered as last resort options. So the WHO has set a target for countries to have at least 60% of total antibiotic consumption being access group. And Newfoundland is above 75% across all providers and also province-wide. So this is, again, looking at prescriptions rate per thousand population, just broken down by age group and also by gender. So the important trend to notice here is that pre-COVID, there was certainly higher use among older age groups. Interestingly, in the past year or two, that has since come down as well, while children previously saw a decrease in rates, unlike other age groups, those rates have also slightly gone up again, though they have remained low. So I'm going to pass it back to Peter to talk about the trends that we're seeing in our province.
Thank you. So we have measured the rate of antimicrobial use in locations, and we find that the use is higher in rural areas. That is, it seems that patients in the city or in a bigger urban location have a lower rate compared to in a rural area. Next slide. And if we zoom in on the Avalon, we can start to see that the city itself is in a lower rate. That's a lighter color, where the more rural areas in the southern Avalon and in the Peninsula's region and onto the main part of the island are increased compared to the city. Thank you. Next slide. So then what can we do? You know, we need to address this problem. We've seen some encouraging trend, but we have a long way to go because we really do continue to have a demand for antibiotics that are unnecessary. And I've seen some discussion in the chat. I want to address that. Thank you very much. Immigrants from developing countries tend to ask for antibiotics. Yes, you're right. Many low and middle income countries have much higher rates of antibiotic use than Canada does. So people who are born in those areas and come to Canada tend to have a higher demand for that type of treatment. Another comment is about, you know, who's responsible? Which doctors are the problem? And the answer is all doctors overuse antibiotics. So we see this in inpatient care, we see this in long-term care, and we see this in outpatient care. By far, the vast majority of antibiotics are given to outpatients. So we're particularly concerned about those providers in the outpatient setting. The outpatient setting is the people that are healthy. It's the young, generally the young ambulatory population who doesn't need an antibiotic. And we're particularly interested in virtual care. So we have evidence that virtual care prescription is higher than it is in in-person assessment. In other words, if I see you by telephone and you're complaining about a cough and a sniffle, I have a greater chance of prescribing than if I saw you in person. And that makes sense because the patient is not examined when they're seen by telephone. So we're particularly concerned about that type of usage. So what can we ask our prescribers to do? In the hospital setting, we want prescribers to target the germ that the patient has. And if you know what this means, it means don't treat with a broad spectrum antibiotic when you can treat with a narrow spectrum antibiotic. Don't treat for a long duration when you could treat with a short duration. And don't treat with an intravenous when you could treat with a tablet. And these are ways that can significantly change the way we use inside the hospital. In the clinic, we want providers to tell the patient, good news, you don't need an antibiotic. We would like to reassure you. And the question about self-limiting illness, how long should you have a cough and a sniffle before you take an antibiotic? The answer is there is no duration of cough after which you need to take an antibiotic. You might have a cough from a viral respiratory tract infection that lasts for 4 weeks of time. That doesn't justify an antibiotic. Furthermore, the color of sputum in the healthy person does not justify the use of an antibiotic. A fever does not justify the use of an antibiotic. There are many other non-antibiotic options, such as an inhaled steroid, a decongestant, an antihistamine, and many other therapies that are available. And we're particularly interested in the parents of children because parents of children are quite worried naturally about the health of their child. and they are quite motivated to take an antibiotic that they may not need. Next slide. I'll keep going here. We need to understand the harms of what we're doing. We compare this to global warming. It's our individual actions day by day that contribute to an ecological problem internationally. And so we're all responsible. We live in a rich country. We have a successful healthcare system. We need to be responsible for the way we behave with these types of drugs, as well as with other types of drugs as well. So then viral illnesses, especially COVID-19, should never be treated with an antimicrobial because that would be unnecessary and unhelpful. And remember that if you pee in a cup and you grow some bacteria in the urine, that's not necessarily a justification for an antibiotic either. Next slide. So we're going to get into some of the syndromes now, and I'd like to interact with you. We have 19 people online. And so I'd like to give after the talk, to give a period of discussion and interaction. And I'd like to hear from you. And you may have your different perspectives on the use of antibiotics. And I'd like to answer any questions that you might have. Let's talk about the syndromes of interest. Colds and runny noses. We call this the sniffles, like a RSV infection, COVID-19 infection, influenza infection, enterovirus, adenovirus. These are benign, irritating, but minor upper respiratory tract infections. Nobody dies of a cold. You might miss a day of work, but you're unlikely to be admitted to hospital, and you're unlikely to get seriously ill. So, and one of the limitations is we don't have a point of care diagnostic test that can tell us which patient has a virus and which patient has a bacteria. But the point is, even with a bacterial infection, this is a self-resolving syndrome. It's not pneumonia. It's not meningitis or other life-threatening infection. We can sort this out by seeing the patient, doing the history, doing the physical examination. This is an upper respiratory tract infection. It is benign. And without antibiotics, the patient will do very well. So remember that coughs and colds are common, especially if you're a child, but that most adults are still getting 3, 4, 5 viral infections per year. You know what it's like. You got a plugged up nose, you got a sore throat, you don't feel like getting out of bed, but you do very well even without antibiotic treatment. Next slide. The next one is pharyngitis or sore throat. This is a super common problem. Generally speaking, sore throat is caused by a virus, not strep throat, Streptococcus, group A Streptococcus. That is a rare syndrome. Probably 15% of pharyngitis in adults is actually strep throat. Now, why do we treat antibiotics for strep throat? We use that to try to prevent an extremely rare complication of strep throat, which basically almost never happens. So we're not treating with antibiotics for strep throat to make the patient feel better. We're trying to prevent a very, very rare complication. And so beware of a doctor who looks in your throat and goes, "You have strep throat." How do you diagnose strep throat? You must collect a swab from the throat. The swab goes to the lab. The lab will grow the organism and report the result as strep throat. You cannot tell strep throat based on physical examination. So please do not request an antibiotic for pharyngitis, and do not request a test for strep throat if it's very unlikely that you have strep throat. Let's go to the next slide. Earache or otitis media is a common respiratory tract infection in children. And if you have children, you know they get feverish and irritable. They don't want to eat. They pull on their ear because they have pain in the deep and behind the eardrum. This is otitis media. Sometimes it leads to perforation and pus comes forward through the eardrum. Still, it's a very benign illness, and children get well very quickly after this. We know in the Scandinavian countries, there's absolutely no antibiotics given for otitis media, and that the outcomes are positive. Children within a couple of days are back running around and going to school and doing what they want to do. So the otitis media, not an indication for antibiotic therapy. Next slide. And we do have a provincial antimicrobial stewardship committee. We work directly with Robert in the Choosing Wisely and Quality of Care initiative. And our job, as assigned by the health region, is to work on reducing this problem. And so we do speak to physicians. We do public awareness. We do interventions such as audit and feedback. We do provide our app. In fact, we'd love it if you wanted to look at our app as a patient. It's called First Line. First Line is a free app. You can download it. It contains our recommendations for antibiotic usage for patients in Newfoundland and Labrador. And that app is regularly updated. It contains appropriate guidelines for which syndromes really do require an antibiotic, generally focused on those syndromes leading to admission to hospital, and which syndromes do not. So we work directly. Thanks, Melissa, for putting that in the chat. Follow the link and download the app and refer to the app, or share that with your family or your other people that you work with. Next slide. We also think, besides what we give to humans, into the One Health strategy. One Health means when antibiotics are used anywhere, it contributes to the problem of antimicrobial resistance anywhere. In other words, if farmers are putting antimicrobials into animals, then those animals become colonized with drug-resistant bacteria, and those drug-resistant bacteria may be spread from animals to humans. And furthermore, if we're putting antimicrobials onto the crops in the fields, and they're washed by the rain into the water and they are consumed by humans, that may also be a mechanism of transmission of antimicrobial resistance. That is, we're talking today about human use, but we really do think much more widely and globally about usage in animals. In fact, the usage in animals, per amount of drug is greater than the use in humans. In fact, a lot of farms give antimicrobials to animals who are not even sick. That is to say, they give them as a prevention or a growth promotion, not because of their effect on killing germs. So the entire indication is incorrect. However, the cows and the pigs get bigger earlier, and therefore they're more profitable to the industry. So you can see the corruption of the indication of the use of the drug is not even for what it was designed to be used for. So we're concerned about all this usage. Next slide. So maybe we can wrap up there, and I'd like to hear from you or get your input or your perspective. Do you have any experiences of taking antibiotics yourself? Are you a physician who deals with this problem? We know that there's a lot of demand from the patient. Sometimes it can be a confrontation that we have to fight with the patient over the use of these drugs. Let me hear if anyone has any perspectives.
So, Peter, I know you addressed some of the questions during the presentation. We talked about the immigrants, or especially when they come from developing countries, tend to ask for antibiotics. You addressed that, but did you address what is the plan to address this actual concern? Why is this happening?
Well, I have plenty of patients that come from other countries, and we have to modify their expectations about appropriate usage. So when a patient requests an antibiotic, because they're accustomed to receiving an antibiotic previously, we must change the thinking. We cannot simply say, oh, we'll just carry on the pattern of what you're used to receiving. And that, of course, applies to a patient who's born in Canada and to a patient who's born anywhere else, is although last year you got this treatment, this year you will not. In other words, the person who decides who gets the treatment is the provider, the nurse practitioner or the physician. It's not the patient. Patient cannot buy this drug over the counter without a prescription. The prescription is the means that the provider controls the overuse problem. And it's the same with responsible use of opioid, and it's the same with responsible use of benzodiazepine. These are harmful drugs for which the provider, the prescriber, me, the doctor, the nurse practitioner must become responsible and act appropriately. Cannot blame the patient. The patient has been treated incorrectly before. It's time to change the expectation.
I got a few more questions here, Peter. Just before I get into that, you'll notice that I put down a link to the CARS report, which is the Canadian Antimicrobial Resistance Surveillance System report, which is an annual report by the Government of Canada. And this will actually showcase usage across the country, but not only in humans, but in agriculture and animals, etc. So you'll get an idea of the usage that Peter got into in one of his last slides. So I have another question here, Peter. It refers to the data, Michael, that you showed, that there was an increase in the number of prescriptions in the summer of 2022. Do we know what caused this? Because this is not the traditional cold and flu season.
Yes, excellent question. Thank you for that. We measure these trends and then we make guesses about the causes of these trends. But of course, we don't entirely know why these trends are going up or going down. One of the main reductions we saw during COVID-19, I think, has to be blamed on or accredited to lack of access. So in the worst of the pandemic in 2020, people were sheltering in their homes. They were not going out to a clinic. They were not going into hospitals. In fact, health deteriorated because of lack of access to care. So that is probably the explanation for the major reduction in usage. It wasn't as if the patient stopped asking because they became educated about the harms, but rather because they simply could not access care. And that's why we're seeing increase after COVID has passed and we've had an improvement in access to care. Generally, respiratory viruses are winter viruses. We see them more in the December, January, February than we see them in July and August. When we see changes in seasons, we should look over multiple years so that we can become convinced that there is a significant change. So a lot of guesswork. I'm not sure I have the exact answer for why there would be an increase during summer.
And I do believe, Michael, in your chart, you do indicate that during that spike, mandatory masks were lifted by the provincial government. So that could be a speculation. So, masks are done and everyone's kind of transferring germs, and then the cough and cold kind of comes around to the population, and then perhaps there's a demand for antibiotics. So I got another question here. Peter, can you define what or give a definition of what defined daily dose means? We showcased that in the rural areas where some of the pockets of the province were highlighted in higher use. But can you compare that to actual volume of antibiotics and then what defined daily dose actually means?
Yes, thank you for the question. We have various ways that we measure antimicrobial use. We can look at prescription rate, we can look at days of therapy over time, and we can look at defined daily dose. It doesn't matter. These are just different outcomes that we use to measure intensity of usage. That is to say, how many humans are taking how much drug over how much time. Defined daily dose is an adjustment that we use to standardize usage over populations. So it includes dose, it includes duration, and it also includes the usual indicated dose for the drug. The outcome, it doesn't really matter, but the point is we need to describe trends over time and we need to try to describe reduction.
Okay, the questions are coming in here now. This has been an excellent presentation, one that everyone should hear. Can we learn anything from the COVID communications, which were effective, and get this message out more widely?
Thank you for that. I think government was very effective with communication during COVID-19 because of the global pandemic. Yes, how do we communicate best with our patients? It comes through the efforts of choosing wisely, quality of care, both provincially and nationally. It comes to government communication. The public health system needs to promote this. I would agree with you that we had strong communication during a crisis, and we have less strong communication after the crisis is over. But you're right, we could do much more with communicating to the public. This could be on the side of the bus, it could be in a billboard, it could be popping up on your Facebook feed. We could do more to try to make Newfoundlander and Labradorians aware of this issue.
We'll start making some TikTok videos, Peter. I got another one. You mentioned that the prescribing of antibiotics was higher with virtual visits by telephone, potentially related to the lack of physical assessment. Do you have any evidence of whether this is the same case for virtual appointments that are completed by a video?
Thank you. I'm a virtual care provider myself, and the assessment of the patient is limited. I cannot perform a physical examination by video. I can make a cursory impression. I can look over a particular wound or a finding on the patient's physical examination, but it's really not the same as having the patient come in person, looking down into the oropharynx, looking down into the external ear, and really assessing the patient by a careful physical examination. Virtual care is here to stay, and virtual care is promoted by government as a means to increase access. And it does increase access. So virtual care has benefits. But we really do feel that virtual care is harmful with this particular problem.
Okay, another question. In your audit and feedback communication to providers, what do you offer and follow up prescribers with high usage? Training of some nature. I'm also thinking of some video training I've seen from the University of Washington in the matter of how to communicate. I'll kind of lay the foundation for that, Peter, if before you kind of dive in, is the fact that our audit and feedback and peer comparison methods don't point out high prescribers. We don't know who the high prescribers are. When Quality of Care and Choosing Wisely took on this sort of initiative, we just wanted to provide medical education, and we didn't want to get into kind of, tapping the roller on some people's hands. So we are quite anonymous and blind to actually who high prescribers are. So when they provided that report, only that healthcare provider knew their actual volume of prescriptions, and Quality of Care and Choosing Wisely did not get into intervening in between high users or low users, et cetera, et cetera. I don't know if Peter, if you want to add anything onto that.
Yeah, and we've taken that a bit farther in the Stewardship Committee and started to contact doctors with high uses and speak to them by phone. Because, peer comparison is anonymous and it is neutral. It says, here's your usage rate. Here's the other usage rate of the other physicians that work around you. Why don't you match with them? And that's a good, strong message. We don't want to publicly shame doctors for bad care, but we do need to target physicians with high usage. And we are getting into doing that. In fact, we have a particular physician who's become convinced about high usage, and we're providing trends to that physician directly and saying, good work, you are showing reduction.
I have a question here. What about signs and symptoms to look for that may indicate a bacterial infection or actually needing an antibiotic?
I consider the threshold as admission to hospital. So that is an easy and objective measurement. You come to hospital and the doctor discharges you, then you probably don't need an antibiotic. There may be a few people who need one, but it really isn't strongly indicated. You come for assessment, the doctor chooses to admit you to the hospital or certainly admit you to the intensive care unit. Then you need an antibiotic. That is a good threshold to use.
Yeah, and advise an open communication between your healthcare provider as well. I think it's just a comment here. I usually get a bad cough with nose running and so upset that I was not given antibiotics while in Canada. But one year, my physician told me to put 3 drops of normal saline in the morning and night to both noses and continue for a week. This is so robust and working. I am originally from Sri Lanka, and I have communicated this to my relatives, friends still in Sri Lanka, and friends in here. They are so thankful for this information from Canadian physicians. So what I wanted to tell is when physicians say that you do not need antibiotics, it is helpful physicians also giving alternative ways to reduce the condition, but personalize any healthcare plans.
Yeah, that's a great comment. In fact,
Absolutely.
our viral prescription pad, which is a tool that we use, it's supposed to be signed by the doctor, given to the patient. Thanks for coming in today. We care about your illness. Here's some over-the-counter recommendations. Inhale the saline, take a decongestant, take an anti-inflammatory if you have a headache or nasal congestion. These are simple over-the-counter non-antibiotic measures, and we know they work. So these are alternative recommendations that may satisfy the patient. The patient comes to the physician looking for something. They don't want to leave with nothing. They want a recommendation. And the viral prescription is a recommendation that we can use to do exactly what has happened for you. And Melissa put it up in the chat there.
Yes, so I got a comment from Harpa. Comparison with self over time is another approach, as speaker shared. Less of the shaming, less opportunity for prescribers to rebuff over difference of their patient population and that of others. It's a good comment, Harpa. I got another question here, Peter. I guess just this kind of leads on from the previous question of when to look for bacterial infections. What about UTIs, etc.?
Thank you. Urinary tract infections are accompanied by symptoms. That is to say, the patient with urinary tract infection has painful urination, incontinence of urine, or fever. And so when the elderly patient has a urine culture but doesn't have symptoms, they have a syndrome called asymptomatic bacteriuria. That does not require antibiotics. Furthermore, and this is a big, big contention, the delirious patient with a positive urinary tract, a positive urine culture, does not require antibiotics. And it's a very, very common usage for the elderly patient in a long-term care facility or in hospital who has delirium to blame the urinary tract infection when in fact that's just positive urine that they have every day. You collect the urine when they're delirious, it's positive. You collect the urine when they're not delirious, it's also positive. In other words, the positive urine culture is not an indication for treatment.
Another question here. Peter, you mentioned that antibiotics in animals translated to humans and explained how, and thank you for that. Does one individual taking antibiotics affect antibiotic resistance in other individuals, those not consuming antibiotics unnecessarily?
In fact, this is the entire ecological problem, is that we share germs between humans, we share germs between animals and humans, and we share germs between environment and humans. So, we have this flora that lives on us and in us, which is very healthy, very diverse community of different organisms that we rely on. And it changes based on where we travel, it changes based on what we eat, it changes based on who we interact with. So yes, the resistance is transmitted between humans from those who took the antibiotic to those who did not take the antibiotic. So yes, this is the entire ecological problem. We can't just focus on one person. We have to focus on usage among all the global situation. Yeah.
Okay, so I don't see any more comments or questions here. And I'm just mindful of the time before we conclude. So, Peter, is there any sort of take-home message you'd like to put out there?
We'd like people in the province to understand this issue. When you come to your physician with a symptom, ask this question: is there an alternative treatment besides an antibiotic? And tell your grandparents and tell your family, because we continue to have a heavy demand in this province for unnecessary treatment, and we'd like to improve that.
All right, so on that notion, this has been a great discussion, everyone. That concludes the time we had for today's sessions. I want to thank Michael for the analytics and Dr. Daley for leading us through a great discussion on this very, very important topic. A big thank you to everyone who joined us online to listen and participate in our discussion. And just a reminder that our recording of this session will be on our YouTube channel, Quality of Care NL's YouTube channel, in the coming days. So thanks again, everyone. Have a great day and spread the awareness. Thanks.